Good evening, everyone, and thank you for joining tonight. My name is Dr. Brittany Bergeron, and I'm here to talk with you about bioactivity in everyday practice. So a little bit about myself. This is me here in the middle. I am a graduate of the College of the Holy Cross in Worcester, Massachusetts, where I obtained a BA in chemistry, and then I did my dental school training at the University of Maryland in Baltimore, Maryland, which is where I currently reside. Proud member of the American Dental Association, and I'm the 2019 past president of the American Association of Women Dentists, currently serving on the board of directors for Dental Entrepreneur Women. And I have a private practice just north of Baltimore City that I purchased about 3.5 years ago. And that was really my first opportunity to be able to experiment with different dental materials. And that was where I came upon bioactive materials and really fell in love with them. Financial disclosure, this lecture is sponsored by the Pulp Dent Corporation. The opinions in this lecture do not reflect those of Pulp Dent. They are my own. Learning objectives, I think everyone has had a chance to review these, but they're here in case you're wondering what we're talking about tonight. So diving right in, historically biocompatible materials are what we have been using in dentistry. Dental materials have been designed to be passive so that they do not interact or harm the surrounding tissue, whether it be hard or soft tissue in any way. The biocompatible materials that we're using in our everyday practice are filling materials, are cements, pretty much anything that goes inside the oral cavity and stays there. So bioactive materials is a very different way to think about things. They were first discovered in the late 60s by Dr. Larry Hench, and he was actually looking for improved soft tissue graft material for soldiers that were returning from the Vietnam War. So he defined bioactive materials as those that elicit a specific biological response at the interface of a material, which results in the formation of a bond between the tissues and the material. So I think it's probably really easy to see how this would apply to dentistry. Bioactive dental materials are actually interacting with the tooth structure. So we are looking at materials that were intended to basically imitate nature, but within the oral cavity. So the bioactive dental materials that we're going to be discussing today stimulate appetite formation, and that helps to seal against marginal leakage, against microgaps, and ultimately to help rebuild tooth structure. These materials are water-based, and that's really important. It's because they're water-based that they're able to be bioactive, that they're able to take place in the ion exchange that would naturally take place between saliva and the tooth. So that's something really important to remember as we go. There are three main types of bioactive dental materials. They're categorized as those that remineralize, those that deposit hydroxyapatite and remineralize, and then those that regenerate the pulp in addition to that hydroxyapatite deposition and remineralization. So we're going to go through just a couple examples of each of these. So we're probably most familiar with the remineralization category of bioactive materials. That would be our glass ionomers. If you've used the Riva Self-Care materials, glass ionomer derivatives, Activa Bioactive, geomers, so Beautifil 2 by Shofu, that's a great product as well. Duramer cement, if you've used that in your practices, that's an example of a bioactive material that both deposits hydroxyapatite and remineralizes tooth structure. And then for the pulp regeneration, that's where we get into our MTA type materials that we'd be using in endo. So as I said, this lecture is sponsored by Pulp Dent. We're going to be focusing today on Activa Bioactive Restorative and Activa Presto. In my office, these are pretty much the only materials that I'm using when I'm restoring teeth. And I'm going to kind of talk to you about the science about it, and then we'll get into some case examples for each of these materials. So focusing on Activa Bioactive restorative material first, we're going to be looking at the physical properties, which you can see here on this screen, and then we'll get a little bit further into the bioactive properties. So looking at the physical properties of Activa Bioactive, the first thing we're going to look at is the strength. Strength of a material is incredibly important. doesn't matter what area of the mouth you're restoring. We know that there are a lot of forces that are generated in just daily chewing, in patients that brucks. We're talking about a lot of stress that's being potentially placed on these materials. So the two graphs that are on the screen show the compressive strength test, which is the graph on the left, and then the one on the right shows the tensile strength. So a review on these definitions: the compressive strength is the resistance of a material to breaking under compression. So you can see that in the graph on the left, we're comparing Activa Bioactive restorative material to the Filtek Supreme Ultra, the Ketac Nano, and the Fuji 9, and that's going to be the case in both of these graphs. So what we're seeing is that the Activa, although it is a glass ionomer derivative, it's really behaving more like a traditional composite. It's comparable to that Filtek Supreme Ultra, and it's outperforming the other glass ionomer materials it was tested against. So then the graph on the right, the tensile strength, which is the resistance of a material to breaking under tension, again, you can see that the Activa is performing more like a regular composite as far as the ability of it to withstand those stresses. In looking at the wear of the material, this is something that I feel like is becoming more and more relevant. This study was done using abrasive and non-abrasive toothpaste. And I'm not sure about those of you listening, but I feel like every patient I have right now wants the whitest teeth possible, and they're all using this really abrasive toothpaste. So this study, although it's been a few years, it's really relevant to what we're doing. So when we're looking at this graph, the bars on the left are using the non-abrasive toothpaste. Those are in the dark gray. And then the bars that are on the right that are the white, that's using the abrasive toothpaste or the Arm & Hammer. And you can see that over 10,000 cycles of toothpaste, which is a lot of brushing, a lot of potential wear, the product that has the least amount of wear when compared is the Activa restorative material. So this is in comparison to Tetric EvoFlow, Beautifil, which we know is another bioactive material, and then some of the glass ionomers. So if you're looking at your patient population, knowing their home care habits can really help you to determine the type of material that you're going to use in their mouth. So the toughness. If you guys are clinicians, bear with me. I know a lot of the definitions and the science can be a little slow, but we'll get to the good part. The toughness of Activa Bioactive is superb. Toughness is measured or is defined as the ability of a strong, hard material to absorb stress and to dissipate forces and resist fracture when a load is applied. This is measured by a deflection at break using a 3-point test, and that's what this graphic here on the top left is showing an example of. So if you look at the graph on the left, you can see that the deflection at break, the toughness or the flex of the material of Activa Bioactive is superior in comparison to the Filtek Supreme Ultra, again, the Ketac Nano and the Fuji 9. This is due to the composition of the Activa Bioactive material. There is a rubberized component to this material that makes it so that you get more flex and less fracture. So when you're looking at this, to say that it's 2 to 3 times, better than composites, 5 to 10 times greater than a glass ionomer or a resin modified glass ionomer, this is a material that's really intended to withstand a lot of force and prevent any sort of fracture or chipping within a patient's mouth. Water absorption. We've already touched a little bit on this, that water absorption is necessary for bioactivity. Ions are exchanged through that ability to absorb water, but you can have too much of a good thing. So Activa is specifically designed to have better water absorption than a traditional composite, but less than a resin modified glass ionomer. And then water solubility, same thing. We're looking more along the lines of the Activa being comparable to a traditional composite, so the Filtek Supreme Ultra in this case, and showing lower water solubility than the other glass ionomers that it's compared against. This helps it to deliver both the bioactive properties that we're looking for, but to still be durable when used in a patient's mouth. And finally, radiopacity. This is something that as a clinical dentist is really important to me. I want to be able to see my fillings on a radiograph. I I hate that feeling when you look at an x-ray, feel like it's usually in the anterior region and you think, is there a filling in that tooth? Is something missing? So when you look at this x-ray here, you can see that the radiopacity of the Activa bioactive material is equivalent to 1.5 millimeters of aluminum. So you will see this on your x-ray recalls when you're following up with your patients. Okay. So switching gears from the physical properties and looking at the bioactive properties, it's these areas here that we are going to touch on next. So the bioactive properties of Activa Bioactive are as a result of the chemical makeup or the structural makeup of this material. There is a reactive ionic matrix that is specifically designed so that this material can be moisture friendly and participate in an ion exchange with the tooth structure. So basically what's happening is hydrogen ions, you can see here, are breaking away from this phosphate molecule, which lets the phosphate bond with the tooth, bond to the calcium in the tooth. And this is what's responsible for the decreased microleakage between the restoration and the tooth. This is how the ionic resin is going to release the phosphate, is because of that really reactive matrix. We're going to see increased marginal integrity because of this bond, and then that's going to help to seal against bacterial leakage. So in theory, decrease the likelihood of recurrent caries. This is a really cool graphic, and I hope this is clear for everyone to see. So this shows the mineral tags or the apatite formation that is happening between Activa Bioactive, which is the top part of this image, and then the dentin of the tooth, which is the bottom part of the image. The apatite formation that happens between the tooth and the restoration helps to really create a tight bond between the material and the tooth. It helps to decrease sensitivity by sealing those dentinal tubules. It helps to decrease microleakage at the margin, and like I said, to prevent secondary caries because you have this strong bond. And I just think it's really neat to actually see this versus just knowing that it's true. So fluoride release and recharge. This is such an awesome property of bioactive materials, and specifically this material. If you have patients in your office that are on fluoride protocols, maybe they're on well water or they're a high caries risk, maybe they're recovering from some sort of cancer treatment or chemotherapy. Certainly those are patients in my office that are going to be at the very least getting a topical fluoride varnish when they come in, but also probably on some sort of a ClinPro or a Prevident regimen at home. This graph is showing you the fluoride release, but also the ability to recharge of the Activa in comparison to the Ketac Nano and then the Triage. You can see we're looking at a period of 3 weeks here. So the area on the left is in the first couple of hours to the first few days, and then we're looking at 1, 2, and 3 weeks. And you can see that not only is the Activa material starting with a higher amount of fluoride, but over a long period of time, it's really recharging and releasing a lot more fluoride than the competing products into that tooth structure. So if you're concerned about your patient's risk for caries or trying to prevent recurrent caries, putting a patient on a fluoride protocol in addition to using these materials can really benefit the patient in the long term. All right, and then phosphate release is also really important. This material is considered to be a smart material because it's basically responding as the body is changing. We know that every time a patient drinks anything that's not water or eats anything, it's going to change the pH in their mouth for on average about a half an hour after they're done consuming. So what this graph is showing you is that as the pH is changing in the mouth, the amount of phosphate that's being released. So at a lower, more acidic pH, this pH 4, we're seeing a higher release of phosphate. And then when the pH is more neutral, pH 7, we're seeing a lower release. So the fact that this material has the ability to basically respond to changes in the mouth is really incredible. And I think pretty impressive technology. It's always really interesting to see how far we've come in dentistry. And this is one of those properties that really makes you realize that we've come a long way. Okay, so in looking at microleakage, Activa in the study was compared to Tetric Evo Ceram, Sonic Fill, and Filtech Supreme Ultra. I've used all of these materials, and I'm sure many of you that are on this lecture have as well. They're pretty popular, and they're all really good composites. So what we're looking at here is after 5,000 thermocycles, the number of samples that had some sort of micro leakage. What's really interesting about this is that the composites were all tested with a bonding agent, but the Activa was tested without a bonding agent. It was just put into the tooth after being etched. So it is performing exactly the same, if not slightly better than standard composites on the market without even bonding, because of its ability to form those the apatite formation and the mineral tags that are going into the tooth. And then if you have less marginal microleakage, it's probably not surprising that you're also going to have less bacterial microleakage. So here we are looking at the number of samples that had no leakage after a period of time. So the red, the left bar on the graph is the Activa, and then the right is in comparison to Vitrabond. So at 20 days, the amount of samples that had no leakage for each material was the same. But you can see that at 40 and 60 days, the Activa is outperforming by having a lower or a higher amount of samples with no leakage. So we're going to switch gears and we're going to talk about Activa Presto. Activa Presto is a newer product than the Activa Bioactive. Activa Bioactive is celebrating 10 years coming up, and Activa Presto is a little bit newer. I've been using this material for probably about 2.5 years in my private practice. So we're going to be looking at the physical properties of the Activa Presto first. This would be the strength, wear, and toughness. So when we're looking at the strength of this product, there was a study that was done at the University of Tennessee Health Science Center that compared the Activa to the, the Spectra pH, the Filtech, and they found that there was no statistical difference between the flexural strength of the Activa Presto and these leading composite brands. So even though this is a flowable composite in compared to a packable composite, the strength is still comparable. And then when we're looking at the wear of this property, the study was done by the University of Alabama School of Dentistry, and it shows that there's no statistical difference in the wear between Activa Presto and Filtech Supreme Ultra. So again, this is a glass ionomer derivative that is responding more like a traditional composite. Review on our vocabulary here. The toughness is the ability to dissipate force and resist fracture when the load is applied. And Activa Presto is here compared to Filtech and then the Beautifil. And the deflection at break of the Activa Presto is greater than the leading composites, meaning it's going to be more likely to flex than it is to break or to crack. So bioactive properties, we're looking at the ability for the material to uptake calcium, fluoride, phosphate, and then also the release of those ions. So again, I just want to stress that the bioactive properties of this material have to do with the technology that created it. So again, we have a reactive ionic matrix that makes it so that the ions can be exchanged between the material and the tooth structure. The biggest difference between the Activa Presto and the Activa Bioactive would be how that matrix is created. So in the Activa Presto, we still see the bioactive properties, but the aesthetics are much better. The material has a very glossy appearance, and that's because of this modified calcium phosphate, or MCP. So this is patented technology to pulp. It's called Krista. I've heard some people kind of ask questions about Krista. They're curious how they get this Krista product. And I think the best way to explain Krista is to say, it's like saying that your home PC is powered by Intel. Activa Presto is powered by Krista. Krista is that modified calcium phosphate that is making these bioactive properties possible. So again, the properties of this, we're releasing that phosphate, calcium, and fluoride and recharging, intimate adaptation to the tooth structure, and then also excellent marginal integrity. So here's a couple of visuals to help to show this. These next 3 slides are going to show the Activa Presto in comparison to the Activa Bioactive, the Beautiful Flow Plus, and then the Filtec. So here you're seeing the calcium release and recharge. And you can see that the Activa is actually, the Presto is actually outperforming the Activa Bioactive in a sense. It's releasing more calcium from the beginning and then recharging to release more over a study that was done over a month-long period. And then if we're looking at the fluoride, we're seeing a similar amount of fluoride release and recharge between the Activa Presto and the Activa Bioactive, but a much higher amount than the competing products or the other composites that are on the market. And then finally, when we're looking at the phosphate release, this is the ability to respond to those changes in pH in the mouth as our patients are eating and drinking and going about their day. And you can see that the Presto has a much greater ability to release and recharge that phosphate. So just to compare these 2 products, they are similar but still different. I'm not going to read this to you, but a couple of things that I would point out that are important to know. And first would be the Activa Bioactive Restorative is a dual cure material. This is something that you can use more like a bulk fill material, whereas the Activa Presto is a light cure only. It's light cure in 2.5 millimeter increments. So that's something that you want to sort of keep in mind as you're working with it. The shade availability is somewhat different for these. When you're looking at the Activa Bioactive Restorative, you're basically your A shades and then an opaque white, whereas the Activa Presto comes in the B1, the bleach, and then also the A4 and A6 cervical shades, which I found is really helpful if you're treating an older population of patients, but you still want to do aesthetic dentistry. The column in the middle is the one that is important. You can see that they're both bioactive, aesthetic, moisture friendly. They're strong materials that are releasing and recharging that calcium, phosphate, and fluoride. They help to counter that low pH attack. And then they're also free from any BPAs or BPA derivatives. All right. So now we're going to talk a little bit about how these materials are placed and used before we get into the case examples. So when you're looking at your patient population in your office, how many patients like this who might clench their teeth or who might brush or grind their teeth? I can say that since the onset of the pandemic, we have seen so many more patients that are clenching and grinding, that are having occlusal wear on their enamel through their dentin, or who are developing buccal abfractions. And these can be areas that are really tough to restore. So material selection is really important as far as the strength of the material, the ability to bond, and how it's going to withstand that wear. I would love to think that all of my patients are compliant with their night guards, but I think we all know in reality that's usually not the case. What about this patient? Looks like they're missing a couple of fixed restorations, maybe some crowns that came off their posterior teeth. Certainly a high caries risk, lots of caries here, interproximal, occlusal, really broken down dentition. Maybe an issue with dry mouth here. Their tissue looks, kind of tacky. That's a patient that I would certainly want on some sort of a fluoride regimen. But knowing that they have dry mouth, that really would make them at a higher risk for caries. This patient here, these are pretty large interproximal lesions. And then if we're looking at this last photo, I think we could argue that there's potentially occlusal decay on most of the posterior teeth. These are patients that, like I said, I would have on some sort of a fluoride protocol, whether it be topical fluoride varnish or a take-home toothpaste, prescription toothpaste, to help to keep them healthy. We see a lot of patients that are on well water, so we have a lot of patients that are on fluoride for that reason. So when I'm selecting materials for those patients, I want to know that the materials I'm using are working with that protocol. When looking at Activa Bioactive, the main properties that I would say you need to know about are that this is a two-paste auto-mix system. So similar to your impression material, or if you've used Tempon or cement that's mixed in a tip, that's what's happening here. You have 2 tubes of material that are mixing in the auto mix tip when it's dispensed. It cures by a few different mechanisms. The material can be light cured up to 4 millimeters, but it also self-cures. So there's a resin chemistry that happens over a 3-minute set time, and then there's also a glass ionomer reaction that's occurring. So you have the option to cure this material or to wait for it to set, maybe a combination of both. And I would say frequently I'm doing a combination of both. And then again, it comes in the A shades and then opaque white, which is marketed as the kids version, but it's basically just the same material in a bright white. When we're looking at the Activa Presto, I have my curing light here to remind you that it is light cure only, and you're going to cure that in 2.5 millimeter increments. So this is going to be treated more like a conventional composite in that sense, as far as you're not going to be able to bulk fill this material. You're going to want to pay attention to the depth at which you're placing it. We have all the A shades, the B1, the bleach, and then that A4 and A6, those cervical shades, which, like I said, in older populations or patients that have a lot of staining, we know that those root areas when you're doing your class 5 restorations tend to be more prone to caries. So using a material that we know contains fluoride and can do this mineral exchange while also being aesthetic is really a win for our patients. So when we're placing this material, here you can see as a picture of that Activa Bioactive in the dispensing gun. So there's 2 chambers here that mix in the tip, and then the gun is more similar to an impression gun. I really like this delivery system. I find that it is much easier to dispense the material when the cartridge is getting low than in a traditional syringe. It's just a lot friendlier to my hands. Personally, if every material could be dispensed like this, I would be delighted. So if anyone at PulpDen or otherwise is listening, that would be my desire. So when we're placing this material, you're going to prepare your tooth structure as you normally would, obviously removing failed material, decay. I like to do some sort of a retentive preparation. I tend to use a pear burr, whether it be a diamond or a carbide burr, because I like to have a little bit of mechanical retention. I'm not talking GV black, really hard cuts, but a little bit of mechanical retention is always a good thing. So you're going to either selective or total etch your tooth structure. You're going to use your bond of choice. If you're bonding in my office, that's the Viva pen. I love that, and I'll show you a picture of that here in a second. You're going to place your Activa Bioactive, and then you're going to light or self-cure the restorative material, and then finish and polish accordingly. So I want to talk about bonding, because in the previous slide, when we were showing the bond strength of the material and the micro leakage, we presented that without any sort of bond being used. So the question that comes up is, if you bond with Activa Bioactive, are you going to interfere with the material's ability to bond to the tooth structure? And the answer is no. And the reason that that still works, that you can still get this apatite formation and this mechanical bond with the tooth, is that a perfect hydrophobic bonding agent doesn't exist, probably despite all the manufacturer's best efforts. We know that bonding agents are still somewhat permeable to the dentinal tubules and the fluid that passes through. So what ends up happening is that the ion exchange between the Activa Bioactive and the dentin actually is going to occur through that bond layer, and it's going to help to strengthen the seal. The way I picture it is that it acts like glue almost. So here's just a graphic of that. You can see here we've got the dentin. Dentinal fluid is flowing through the tubules, our adhesive layer, and then when we're placing the Activa, the ion exchange is still occurring through that layer of bond. In looking at the Activa Presto, very similar as far as how you're going to prepare and place that material. Prepare your tooth surface, selective or total etch, bond of choice, placing the Activa Presto. Again, in your 2.5 millimeter increments, you're going to light cure this restoration and then finish and polish. This material finishes with a very high, very aesthetic gloss. So if you are careful in placing this, or you're shaping it as you're placing it, you should really have to do minimal finishing and polishing when you finish your restoration. So probably the biggest learning curve involved in these materials, in my opinion, would be selecting a matrix. These are both really flowable materials, so you're not able to pack or condense the material into say, a proximal box. Prior to using Activa products, whether it be the Presto or the Bioactive, I was using conventional Toffelmeyers. I had no problem with them. Wedge the band, burnish really well, you get a good solid contact. Now I've switched over to the most part using a sectional matrix. This is pictured the Triodent system by Ultradent. That's what I use in my office. There are a lot of other really great sectional matrix products. Garrison makes a great one. There's so many out there. So whatever you're using, you just want to make sure that you're really getting a good wedge as far as sectioning the teeth and separating them so that you have a nice firm contact, because these materials are not very easily packable. If I'm not using a sectional matrix in my office, I'm using these bands. This is the Omni Matrix from also from Ultradent. It's a disposable Toffelmeyer. It's all in one. The benefit of this is that this angle of the band can be at any angle. You're not limited to just the 180 or 90 degree bend in the band. You can make it any angle that you want to. So if you're trying to get more than one band in place, you can do that with a lot more success. This is the orange handle. It's kind of hard to tell if it's orange or red, but it's orange. And this is the equivalent of a whole band in thickness. And then we also use the red Omni Matrix, which is actually a Mylar on a Toffelmeyer. And we use those when we're using either material in the anterior or posterior, because it makes it so that you can cure all the way around. So if you're doing a buildup, for example, and you want to do a bulk of material or cure more at once, you can cure from every angle while still keeping the material confined with the matrix band. So matrix selection is very important. All right, now the fun stuff. Now we're going to get into some cases that I've done in my office. My disclaimer would be that I am not a professional photographer. And sometimes we've got my office manager taking photos, my hygienist, my assistant, it just sort of varies. So I would certainly welcome any constructive criticism or tips, but just kind of bear with me on some of these photos. So we're going to be talking about the Activa Bioactive Restorative Material first. This is a case where we have a patient who is an extreme bruxer, and she's not wearing an appliance. She doesn't really believe that she grinds her teeth, despite the obvious wear. A lot of her dentition has been restored with crown and bridge, some of it being PFN, some of it's zirconia. And so her teeth that don't have those full coverage restorations are seeing a lot of wear. You can see here she has an occlusal amalgam in number 20, and she has fractures from the mesial, the distal, the lingual, and then enamel craze lines across the buccal cusp, and even some wear on the enamel that you can see here. In a patient like this, my ideal treatment would be to crown the tooth. I have an insurance-based practice, and her insurance says, well, unless there's a piece of tooth missing, we're not paying for a crown or a buildup. Obviously, I don't want to leave the patient in a situation that her tooth might break. So this, in my opinion, is a great example of when you would use a bioactive material, something that's going to give a great bond strength, have a high wear property or resistance to wear, and then also those components for that ion exchange to help to prevent future decay, where you can see this restoration is obviously leaking in these areas where the tooth is cracked. So here's our initial photo on the left. On the right, you can see that we've cleaned out the majority of the fractures. We went on to smooth things up a little bit, but general idea that really the majority of the tooth is going to end up being filling material at this point. And she has crowns on either side of this. So this is sort of the last man standing on this arch. So like I said, you're going to selective or total etch. This is the Viva pen that we use in my office. If you're not using this, it is fantastic. It's an Ivoclar Vivident product, and it has this gauge on the end, so you can actually see how much bond is left in the pen. There's no guessing of is it empty or is there still something left in it. You have an actual gauge. So I really like that. The tip is a cannula with a little micro brush on the end, so it makes it really easy to get into those hard to reach places to apply that bond. So then we're going to apply our Activa Bioactive. We use A1 for a lot of our patients. I would say A1 and 2 are our most popular shades. And then here's our final restoration. So this is definitely an improvement for this patient as far as this tooth being back to a point of stability. Long term, will she still probably end up needing a crown on the tooth? Absolutely, especially where she's not wearing her night guard. But for now, we've been able to give her a strong restoration and make this a lot better of a situation for her. And she's had this restoration for about 7 months now, and she's feeling great. She hasn't had any sensitivity, sensitivity chewing or to hot and cold. So here's a patient that, again, when we're looking at material selection, this patient is in her late 20s. She has caries on every single tooth. Home care is not great. It's okay. She's a morning brusher. She's not brushing at night, minimal flossing. If you look at this photo, you can see that she's obviously bruxing at some point or to some degree. She's got a lot of wear on her first molars and her second premolars. And she has this failed composite restoration in number 30 that has some wear here at the margin and then also some recurrent decay. This patient is on a fluoride regimen. She's getting fluoride varnish applied every time she's in the office, both when she comes in for hygiene and when she comes in for restorative. And then she's also using Climpro 5000 twice a day at home. So we've taken out this old filling in the tooth. You can see the decay was relatively deep on the mesial portion. We opted to place a base or liner in this tooth. In this instance, we are using the Limelight Enhanced, which is also a pulp dent product. This is probably my favorite base or liner. I like that you don't have to mix it. It's not technique sensitive. You don't have to worry about the liquid to powder ratio. It comes out and it's ready to go. And in my experience of the various products I've used, the adhesion of this is really superior. So we use Limelight Enhanced on a lot of our cases where we're concerned about the depth of the restoration and the potential for sensitivity. So we're going to, again, selective etch, bond, and then apply our Activa. Here's a photo of the Activa being dispensed. So you can see that the material is being mixed in the tip. And then after the auto mix tip, there's this metal cannula, which you can bend in any direction, and it also rotates. So whether you're doing a maxillary or mandibular restoration, posterior, anterior, you can really bend the cannula on this to get down in the proximal boxes of restorations, especially, a lot of times with premolars, depending on the size of the tooth, that proximal box area can be really small and it can be difficult to make sure that you're getting the material really smooth in the box. But this cannula fits in all of those hard to reach places. So you know that you're not going to have any air bubbles or voids at the margin next to the band, which is really important. And then here's our final restoration. So in a patient like this, when we're talking about material selection, with the fluoride protocol that she's on, every time she uses it, she's getting that release and recharge to help to prevent recurrent decay. And this has become somewhat of a marketing strategy in my office for fluoride treatments. Fluoride coverage in adults is usually pretty low if you're in an insurance-based practice. But the way we offer this to patients is to say, you've had restorative work in the office. Would you like to recharge or reboost your fillings? We can apply this fluoride varnish, which will be absorbed into your filling material and transferred to your tooth to help to keep it healthy. And patients are delighted that we offer this service, and it's like a no-brainer for them. They want to prevent having dental work done. We would like to prevent from redoing their fillings over and over. So it's really a win-win and ends up being somewhat of a production booster as well for our hygiene department. So this is kind of a funny case. We only have a couple of photos here to share. I don't know if anyone's ever had this happen, that your hygienist comes to you and they say, Doc, don't get mad. And you think, uh-oh, what just fell out? What just came off? What just happened? And things happen. It's usually not their fault, but it's one of those like, uh-oh, what am I about to walk into? So that's what happened in this situation. This is a periodontal patient who, again, has pretty poor home care. He had a lot of failing restorations that were on the treatment plan and were slowly kind of chipping through it. So during his routine period maintenance, this buccal composite on number 30 just popped right out. There was recurrent decay underneath. We actually had to use our diode laser to trough some of the tissue so that we could actually expose the tooth. He had a lot of localized inflammation as a result of the leakage that was taking place. So once we get the tooth prepared, again, we're etching, bonding, applying our Activa Bioactive, and then this is the final restoration of the tooth. We have seen him back on hygiene recall, and the tissue has just healed in such an incredible way now that it's not up against a rough restoration that's leaking at the margin. He knows that long-term, this tooth has a relatively poor prognosis because the restoration is into the furcation area. But what I like about this material is since it's dual cure, if you can keep the area dry, you know the material is going to set, even in an area where your curing light is going to reach. There are no thoughts in my mind that, think that the curing light is reaching into the furcation space. And again, we can only go so deep with this, but knowing that the material is going to set and continue to bond to the tooth, that makes me feel a little bit better, knowing that we might be able to nurse this tooth along until the patient's ready for a more definitive treatment, which would likely in this case be an extraction and an implant because of the periodontal involvement. So this is going to be the final case that we talk about with the Activa Bioactive. This is not my case, it's actually my dad's. My dad is an oral and maxillofacial surgeon, and he practices in Anchorage, Alaska. And this was a patient that he saw while he was on trauma call for one of the hospitals in Anchorage. He listened to a lecture that I gave a couple years ago talking about the strength of the Activa Bioactive restorative material, and it just so happened he had the opportunity to use it. So I don't have initial photos of this patient, but I'm going to walk you through the case. This was a self-inflicted gunshot wound, a failed suicide attempt of a middle-aged man using a pistol. When the splint was originally placed, the bone in the maxilla was not suitable to have arch bars placed. So normally you would place arch bars if you're dealing with some sort of a jaw fracture, and then the patient would be wired or rubber banded shut while the jaw heals. In this situation, the bone didn't qualify for that. So initially, all of the maxillary dentition was present, and my dad used the Activa Bioactive material back and forth across the maxillary teeth from canine to premolar to help to stabilize the teeth so that the bone would hopefully heal around them. As time went on, it was evident that teeth 9 and 10 were not going to make it. They were having a lot of bone loss. The roots were completely exposed. So they were cut free of the splint, and the rest of the material was left in place, which is this photo that you're seeing here. The splint goes from 6 over to 12 or 13, and it was freed of teeth 9 and 10, and they were removed. What's really important to say is this patient was eating a blenderized or a soft diet. So he was chewing on his teeth at this point. So when you look at these next slides, this is an occlusal view and then another angle of a buccal view of this Activa bridge. This is not reinforced with wire or any sort of a ribbon framework. This is just the material that's been bonded across these teeth. You can see that in time, the bony defect that was present with 9 and 10 has also spread to 11 and to 12. So from the buccal view here, you can see that the whole root is exposed, and then you can see that there's actually an opening in the palate where that bone loss was occurring. But these teeth are still in place, and they have still been used because the Activa is holding them in place. So this is, I think, just a really cool example of the strength of this material and what it's able to do outside of just the restorative dental setting. And, technique-wise, a lot faster to place this material than doing some sort of a composite bridge with your PFI and everything else. So long-term, the patient did end up losing his canine and premolar on the upper left. The area was sutured and is now healing really well. But I think you can make an argument that teeth 6, 7, and 8 were saved by the fact that that bridge was in place and preventing them from being mobile, so that at least he's not being, completely edentulated on his maxillary arch. He's able to keep some of those teeth, and then we'll maybe be able to wear some sort of a removable device. So switching gears and talking about Activa Presto, this material is really fun, and I hope you guys will give this a chance because I've really enjoyed using it. First case that we're going to go over is just sort of simple restorative in the anterior region. We have caries on 9 distal, as you can see here, and then also 11 incisal. We're going to prepare those teeth, apply our matrix. We're just using a standard Mylar here. We're not using the one that's on the Tafelmeyer. We're going to etch, bond, and then apply our Activa Presto. These photos are not to show you that I am sloppy when doing fillings, but I wanted to show you that this material is truly very stackable. It's not something that's going to flow like a light body impression material or maybe some of the other flowable composites that you've used. You can take this material and lay a line down and literally stack it back and forth, ribbon it on itself, and it will stand up. So here, just showing that you can put a line of the material and it's not going to run or move. It's really going to stick and maintain its shape. And then same thing here, I've dispensed this droplet to show that it's not falling, it's holding at the end of the cannula tip. And this makes it really great in a situation where you're in direct vision, you're working your mirror, maybe you're in a hard to reach area and you don't have to worry about making a mess that you're going to have to clean up or trim later or wasting material. I mean, let's face it, we're all looking at increased costs, and the last thing we want to do is waste material that is just money being lost when we're treating patients. And so here's our final restorations in place, and then a before and after comparing these two fillings. So this is a situation where I used Activa Presto to do a core buildup, basically because I wanted to see if I could. I wanted to see what it would look like, how easy it would be to work with. Typically, this is a situation that I would use the Activa Bioactive restorative material because it's bulk fill. So I know that I can fill up a whole prep or endo access, set the top layer and keep working. It's very efficient in that way. But I'm always curious about testing the limits of materials and what they can do in a controlled manner, of course. So this patient presented to our office. He had been missing the crown on number 18 for an unknown amount of time. He guessed at least a couple years. You can see here that in the mesiolingual line angle, he had had some sort of a pin to retain that buildup, but everything has now been lost. So we basically went in and smoothed the area of the old pin. We weren't able to retrieve it. We placed another pin just buckled to where the initial pin had been, cleaned up the caries, and then applied our matrix band. So this is an example where we use that clear mylar on the Tafelmeyer to do the buildup for this tooth. And I did that because I know that when I use the Activa Presto, because you're really able to shape and stack this material, even though it's flowable, I could basically carve out the design of the material and then be able to cure it 360 degrees around and essentially fill and cure in one step. So we're going to total etch and bond in this situation. Here we are in the photo on the left, placing the Activa Presto, and then the area on the right is before we've cured it. We're getting ready to kind of scoop out and shape the material. And then this is our final core buildup here with our before and after pictures, and it turned out great. I was really pleased. You know, we're putting a crown over it, but it's a beautiful restoration. So a couple of cosmetic cases. This patient came in, this was a workers' comp case. I had not met this patient before. He was leaving work and the wind caught the door he was going out of and it smacked and hit him in his front tooth. So he came in not necessarily in pain, but saying that his front tooth was uncomfortable to his lip and he, was feeling self-conscious about the way it looked. Before anyone comments, I realize he has a significant amount of calculus. He's now on our schedule for hygiene, but at the time his chief complaint was this front tooth. Couple things to note here. You can see that the angulation of the roots on 8 and 9 are very different. Number 9, the root is more distally inclined, which makes it so that the incisal edges of these teeth are not even. The mesial edge of number 9 is going to sit higher of number 8 in the final restoration. So we prepared this tooth. You can see here, hopefully where the restoration was dry, that we beveled a little bit more than halfway up the surface of the tooth. We've restored this with A3 Activa Presto, and we're able to get a really nice result for the patient. He was delighted. He said, "This looks better than my tooth actually ever looked," which of course I had never seen that, but I was really happy that in one day we were able to get him back to smiling. And I'm sure his employer was happy that we were able to do this without, a crown or a more costly restoration for the patient. And then being in Maryland, we see a lot of lacrosse players. I wish they would wear their mouth guards, but they're not. This was a case of an adolescent patient who was playing lacrosse, and it was actually friendly fire. He collided with his teammate not wearing a mouth guard, and then his helmet didn't have a cage, so he fractured off 8 and 9. Again, wasn't having any pain, but was very concerned about freshman year of high school or sophomore year of high school with broken front teeth. So cases like this are important to have a conversation with both the patient and the parent, because you can see he's got a diastema between 8 and 9. And when you see the later photos, he's got somewhat of an anterior open bite. So one of the conversations we had was, is orthodontic treatment in the future? Because if it is, then we're going to leave the diastema and just try to restore the teeth as they were. If it's not, would you like us to close the space? Is that something you're interested in? So I always have those conversations to start, because it makes the final, plan much easier to move forward with. So we prepared the teeth, again, etch bond and application of our Presto. And then here are our final photos. So we restored 8 MIDFL and then 9 MIFL. You can see that once the teeth are rehydrated, we've got a really glossy, really aesthetic restoration on these teeth. Really proud to say that he's now wearing a custom fit athletic guard every time he plays lacrosse. So that should be the last time that we have to do these restorations. And then he'll be entering orthodontic treatment, like I said, to help to close that diastema, as well as treat the anterior open bite. But again, a case that patient and parent were really delighted with the same day result, and something that was really aesthetic, that people aren't going to look at the patient and know that they just had work done, right? So this is the final case that I'm going to present to you guys. This is a situation that maybe I didn't have to use a bioactive material, but I'll kind of talk to you down the road on why I decided to. So this is Lisa, and Lisa has a history of periodontal disease. She is absolutely a smoker. She smokes about a pack a day and has for decades. So she presented to the office saying, my front tooth is, it's loose. I'm doing everything I'm supposed to be doing. I'm worried it's going to fall out, and I don't want it to fall out. My parents had dentures at 50. I don't want to have fake teeth. What can I do? So we sent her to the periodontist for an evaluation. The periodontist wants to remove her tooth and place an implant. She comes back to me and she said, Doc, I would love to do that. I just can't afford it. What can we do? Is there an option? So it's like, okay, you'd love to think there's always another option. So we talked to her about something removable. She's not interested. Can't do the implant. This tooth is really mobile. So I said, well, kind of a different view, maybe an older approach to dentistry, but we can try doing this natural tooth Pontic. This bridge won't last you forever, but it can definitely give you some time to save up for the implant and to move forward. So she wants to try it. I'm excited. You can see on the bottom left here, this is her lips retracted. She's got a really heavy frenum pull. It pulls to the left, and maybe that's the reason why she's got so much more recession on 9 than she does on 8. Otherwise, the recession across her dentition is pretty uniform. This is Lisa opening about halfway. You can see that her lower plane of occlusion is definitely going to factor into any sort of restoration that we're doing. Those lower mandibular anterior teeth are really super erupted. And so that's something that we're going to have to factor in with our restorative material as far as the wear and the strength of that material. These are Lisa's radiographs. I show you these so that you can see she really has the one main vertical defect on 9 mesial. 8 has about 50% bone, so maybe not ideal for splinting. But when you're looking at her lateral incisors, they've really got the majority of bone present, maybe 20 to 30% bone loss around those teeth. So in doing our splint, we opted to splint 7 through 10 versus just 8 through 10. I wanted to help to give 8 a little bit of extra support. So here's a view of retracting. You can see she has a really strong frenum attachment here. And, from these 2 photos, I hope you can see that this patient's really doing what she's supposed to be doing at home. She's brushing, she's flossing, she's using proxy brushes and a water pick, and her tissue is generally healthy and a really healthy color, which is part of the reason that I was willing to move forward with this procedure, is she's doing what she's supposed to keep things clean. So you can see here, we used our diode laser to perform the frenectomy. We basically relieve the muscle attachment down to the periosteum, for those of you that haven't performed that procedure, and then we remove the tooth. We then grafted the socket and put sutures in to help to seal everything. Here's our cameo of her number 9. You can see that although the tooth was really super erupted, it's otherwise in good shape. The root of the tooth is healthy. There's maybe some stain, but no caries. So it's otherwise a really good tooth that we can make this natural bridge out of. We're going to cut the root of the tooth in a similar pattern to the recession on her other teeth. So I start by cutting the root off about halfway because I wanted to be able to shape and round the pontic just like a pontic would be rounded on a bridge that was made by the lab. We used our Activa Presto in this situation to basically tack the tooth in place so that we can check the specs. Our patient is fairly numb here. The tooth is sitting maybe a little higher than where it finished, but I wanted to make sure that I could get this tooth in place. If we go back to our starting pictures, you can see that there was a diastema at the start. The tooth was long and it was a little bit more forward than her other teeth. So I wanted to make sure before we actually put this bridge in place, I could get it back in. So here's our facial view and then our palatal view of that tooth sitting in place and tacked. And you can see where we've trimmed the root basically to just come to the socket. We didn't take photos of the next step where we're actually preparing the tooth, so I'll just kind of talk you through it. We did this under local anesthetic, and we sort of got to a point that enough was enough with the photos, and we have to respect your patient's wishes when you're doing these cases. So we did a ribbon-enforced, fiber-enforced splint. So we're basically cutting a notch in the back of tooth number 9 so that we can splint across these anterior teeth. So we cut this notch out, we laid a layer of the Activa Presto, and then bonded the ribbon across these teeth, kind of like you would do a fixed lingual retainer after orthodontic treatment. We then added another layer of composite across and another layer of the ribbon. So there's actually 2 layers of ribbon reinforcement with 3 to 4 layers of composite over top. So here's the immediate post-op of our bridge. We have not trimmed, shaped, or polished this at all. This is how glossy and shiny the Presto is immediately after placement. Why is this important in this case? You're never going to see this. Well, it's important to me because this patient smokes a pack a day and she has such intense staining every time she comes in for her quarterly perio maintenance that my hope in using a material that was so polished and glossy is that it's going to be a lot easier for my hygienist to polish it and to get the stain off. Okay, so this is the immediate post-op photo of the lingual view of that bridge. Here's our anterior photos. You can see we did a little cosmetic shaping of the edges so that they would be more even. And we were really able to match the overall recession, we'll say, of the surrounding teeth with the length of that root. So this is her opened. You can see the edges are pretty even. And then this is her trying to smile as best she can with a numb upper lip. This is the patient 10 days post-op. You can see that 10 days, I would love to say that she didn't smoke after extraction, but I know better. So to say 10 packs of cigarettes later, she doesn't have any stain on this composite. It is still shiny and smooth, which to me is awesome. And I'm very optimistic about how it's going to look in the future. Like any good patient, she removed the sutures on her own because they were annoying her. So we lost some of our graft material here, but I'm hoping this will fill in with soft tissue. And then our frenum area where we did the frenectomy is healing really nicely. We talked about her bite in the initial slides, and you can see this is actually her lower anterior tooth that is sticking up interproximally. So the majority of the occlusal adjustment that we had to do was not on this fiber reinforced bridge, but it was actually on the root of the tooth that we removed. So the root, if you see it from the right angle, is maybe a little bit narrower, smaller than that of the surrounding teeth. So just to review these photos, this was initially how Lisa presented to us with her super erupted number 9. This was immediately post-op. She was trying her best to smile even though her lip was numb. And then this was her 10-day follow-up photo where she is just cheesing. In a case like this, we ended up with some black triangles. They are not very aesthetic, and I would point that out, and it's something my eye is drawn to. But for this patient who the alternative was losing her tooth, she's delighted with the result. And I know that we put a restoration in that we're going to be able to keep clean and keep in her mouth for a long period of time until she can either afford the implant or decides what the next steps are. So a quick kind of review here. I hope that with the cases I presented, I've showed you that these bioactive materials, whether it be the Activa Bioactive, the Presto, other materials on the market, they're really indicated for every restoration where you would use a traditional composite. The fact that they participate in the ion exchange, the calcium, phosphate, and fluoride, just means that they are working to benefit the patient as far as keeping their teeth healthy and for the dentistry to be longer lasting by preventing any sort of leakage or recurrent decay. And then again, the aesthetics and durability of both of these materials really make them good treatment for the aesthetic zone, the smile zone, as well as the areas of heavy force, again, as hopefully I've showed you in these cases. So I see that there's some questions in the Q&A. I'm going to put up my contact information. We have just a couple of minutes to go over these questions, so bear with me. I'm going to try to get to these. Let's see. Bear with me, lots of comments and fewer questions here. So someone asked if I'm curing the bond before placing the Activa. Yes, I am curing the bond. I just didn't show that step. So I am using the bond as the manufacturer would suggest. So I'm, doing my selective or total etch, rinsing, drying the tooth, applying the adhesive, and then curing that before placing the Activa material, whether it be the Bioactive or the Presto. Thank you for asking that. I'm sorry I didn't clarify that. And the material for the liner is Lime Light, lime like the fruit, L-I-M-E, L-I-T-E, enhanced. I guess when I said it, it sounded like line right. And then somebody asked when I'm using a bioactive material, why am I using a liner at all? I guess I do it as a feel good. I don't want my patient to have sensitivity. Some of these restorations, when you were looking at the outline of the pulp chamber, I just want a little bit of a buffer between the restorative material and the pulp chamber. I'm sure there are other docs that don't do it that way, and it's not super often that I use it, but it's usually when I'm concerned for patient comfort or anticipating that they might need a root canal. And another comment that using Activa Bioactive, doc has found it to reduce biofilm buildup. Yes, and that's why I really like it for these class 5 restorations. I've found that it's much easier for the patients to keep clean, and that's probably because of the polishability of that material. There are a few more questions that it looks like I didn't get to. My contact information is here. You can reach out to me either on email or social media, and I would be happy to either discuss use of these or to answer your questions offline. So I want to thank everyone for joining. I especially want to thank Pulp Dent for giving me the opportunity and for their part to really, raise up and promote women in dentistry and female speakers. I'm really honored to be part of their team, and I hope to see you all again on a future lecture. So thank you and good evening.